Welcome, everyone. Thank you very much for joining us today. My name is Dr. Louise Ivers, and I am the director of the Harvard Global Health Institute and professor of medicine and professor of global health and social medicine here at Harvard. I'm delighted to welcome you to HGHI's Coffee Sessions, our virtual series that brings together voices from across the global health landscape working to advance global health equity. In recognition of the growing complexities around the US's engagement in global health, we are focusing this year on understanding and considering the impacts of changes to US policy and financing regarding global health collaborative efforts. I have a couple of notes. This session is being recorded through Zoom, and the recording will be made available on the HGHI website and YouTube page in the coming days. We plan to have time at the end of the presentations and discussion for your questions. So if you have a question, please submit it through the Q&A feature on the bottom of your screen. We're going to do our best to get to those questions during the Q&A portion of today's event. With that, please allow me to introduce our speakers today. They both have tremendous experience and expertise, and I'm thrilled that they've agreed to spend an hour with us this morning. Dr. Angeli Achrekar is the Deputy Executive Director of the Program Branch at the Joint United Nations Program on HIV/AIDS and an Assistant Secretary-General of the United Nations. Welcome. Prior to joining UNAIDS in January of 2023, Dr. Achrekar served as the Principal Deputy US Global AIDS Coordinator for the US President's Emergency Plan for AIDS Relief, otherwise known as PEPFAR. Over the past 20 years, with the US government and PEPFAR, she has held prominent positions helping to lead the largest global health effort of the US government to ensure life-saving HIV prevention and treatment services to millions of people around the globe and strengthen health and community systems across 50 countries. Over the years, she has helped evolve UNAIDS program for more person-centered care, protecting and increasing HIV/AIDS gains, while also capacitating countries for broader healthcare delivery. She holds a doctorate of public health from the University of North Carolina at Chapel Hill, a Master of Public Health from Yale University, and a Bachelor of Science from the University of California, Los Angeles. Dr. Stephen Morrison is Senior Vice President at the Center for Strategic and International Studies, where he directs the Global Health Policy Center. Since 2018, he has led global health security discussions at the annual Munich Security Conference, and through several high-level commissions has helped shape decisions in US Congress and the US administration on critical issues, including HIV/AIDS, reproductive health, gender equality, health security, and pandemic preparedness. Dr. Morrison previously served in the Clinton administration on the Secretary of State's policy planning staff and on the House Foreign Affairs Subcommittee on Africa. He is also director of the award-winning documentary, The New Barbarianism, which is a very sobering and important documentary examining violence against the health sector. Dr. Morrison taught for 12 years at the Johns Hopkins School of Advanced International Studies and holds a PhD in political science from the University of Wisconsin-Madison and is a magna cum laude graduate of Yale College. Dr. Achrekar and Dr. Morrison, it's an absolute honor to have you with us here today, and I'm going to dive us straight into discussion by posing to each of you a question that's going to help frame the conversation. As we talk about the US's evolving role in global health, how would you characterize this moment in time, especially from the point of view of the financing for global health? What does it signal for the future of international health cooperation, equity, and preparedness, and what is at stake? Can you explain to us and our audience what you see as the scope and the scale of what we're facing? And I'll maybe pass to you, Dr. Achrekar, to start us off, and then to Dr. Morrison. Thanks.
Thank you. Thank you very much. It really is such a pleasure to be here with you today, and really grateful for the invitation and the warm welcome. Um, I want to start first, though, by really expressing my deep and unwavering solidarity with Harvard University, your faculty, your staff, your students. In a world that is much too divided, Harvard stands as a beacon of truth, of science, and of service to promote global health. And just really grateful to be part of this discussion today. Um, so your question around the U.S. evolving role and what that signals in terms of the future. Well, I would say, sadly, it signals less global cooperation. It signals less equity. It signals less preparedness for future pandemics. This is really a moment in time where we are at a once in a generation crossroads, and the choice is ours, which direction we choose. We either reverse decades of progress that will lead to a resurgence, or we realize our goals. We either retreat to the past or we rebuild for the future. We either step away in isolation or we step up in global solidarity. And, you know, this is the crossroads that we're at right now. What's at stake is, without sustained US leadership, without the leadership of other countries as well stepping up, what's ultimately at stake is millions of lives could be lost. We risk unraveling decades of hard-fought and won progress. We risk wasting significant investment and effort around the globe. And for the US in particular, power and influence in the global health arena could be diminished, and a defining chapter of American leadership in global health would close. And this is at a time when the finish line on many of these areas we've been working on together is in sight. So I'll stop there.
Thank you. Dr. Morrison?
Thank you very much. It's great to be with you all. Louise, we cooperated previously several years ago on Haiti and cholera, and you were very generous in your contributions to that very dramatic moment. Angeli and I have worked very closely. She is much admired here in Washington, D.C. She showed remarkable courage and resilience in heading up PEPFAR during COVID. Which was an extraordinarily stressful and difficult period, and we owe her a great debt. And it's good that she's at the helm there at UNAIDS in this next critical crisis, which bears a lot of resemblances to COVID in many respects. And I also want to thank Elise Mullenkamp and Bethany Mitchell and Joseph Viola for their work in putting this all together. This is very timely for a bunch of reasons. I hope we'll get to talk a bit about the World Health Assembly and the WHO reforms, and I hope we have the Gavi replenishment coming up in June, a very big test moment for what this all means. In the US government, we've got a skinny budget that tells us certain things. We've got Congress coming back to the table. We have massive reforms of the State Department unfolding today, tomorrow, into Monday, Tuesday of next week. So this is a rolling picture, but let me offer some quick summary remarks. I think it's the conclusive end of a golden era, and it's the beginning of something else. And this something else is, we can call it a reset. It's not going to be a restoration to the status quo ante. We are going to operate on the assumption that we will have perhaps 50% of the budgetary base that we had before. And that's a shocking reduction. It's driven with, obviously, by the dramatic and shocking reductions in US support, but it's bigger and wider than that. It's the UK, it's Canada, it's France, the EU. There are multiple factors that have come into play It's not just populism and the revolution that started in Washington with Trump's second term. It's related to climate. It's related to the geopolitical realities of the Ukraine war in particular, and what that's done to budgets in Europe. In particular, it's the aging of these programs. These global health programs have kind of slipped into a second-tier status. The leadership, those are the champions, are aging out. And there's obviously populism. There's other forces. But what this has done, of course, is expose the deep dependence, particularly in Africa, upon these programs in terms of health. So there is a reckoning happening right now. We can talk about Africa CDC. We can talk about some of the other deliberations. I think at the World Health Assembly, this was the top topic of, okay, how are African countries going to now take control of their fates, with what measures, what strategy to try to avoid the worst outcomes and put their health programs on a much more stable footing. So that we've entered this period where, particularly for Africa, that is now a centerpiece. And related to that, obviously, is debt relief, because these countries, they have very narrow budget windows, and they have many of them have excess debt, some less so, but we can talk about those countries better equipped to manage this. Another point I want to make is that it's not just global health that's being impacted here. When you look across the board, the research and development scientific enterprise that upon which global health rests, and many other, the future of innovation for all of us, the scientific enterprise is on the table, certainly in the United States, and we cannot overlook that reality, which is twinned with what's happening on global health. On global health security, the programs and the defenses around bio threats, which have come to be merged in a way with global health in the COVID era and come to be seen as part of our broader whole, those programs are also at risk. And I would add that emergency humanitarian programs, response programs, too, are suffering significant uncertainty and reductions in funding levels. So when you combine those four things, they all have a health security dimension. They all require close attention as we look at this. What does this mean? It means we have to come up with an agenda that's on not just being shocked, we have to focus on what the impacts are on the population served and what are the projections looking forward. But we also have to ask ourselves, what is the strategy now going forward? It's going to have to rest on realism, on reform of our institutions, on trying to stabilize programs as much as possible. We're going to see new forms of financing emerge. We should talk about that. There has to be innovation in financing. There has to be an address, within our own publics. We are seeing half of our public here relatively indifferent to these changes that have happened. Deep distrust, deep collapse of deep skepticism of these investments and of what they mean for U.S. leadership in the world. We need to have a strategy of engagement that demonstrates to our own populations that these are worthwhile preserving in some new form. I'll stop there. Thank you.
We have fantastic. Thanks. You've given us a lot to kind of frame the conversation and think about diving into in the time we have. And I definitely want to come to like the what now and what for the future, etc. But maybe I could just ask you a question, because I think in terms of the scope of the United States' contribution, say, to overseas development assistance, what I think is true is that there are two things. One is that there's generally a misperception about the amount of money from the general public, the amount of money that the US contributes within the federal budget. Yes, yet it varies to be around about or less than 1% of the federal budget. It has gone up and down a little bit over time. And that the way in which the money is spent, there's sometimes a misperception that there are no checks and balances on it, or that it's not maybe very strategic. And yet, even though that's a relatively small amount of the federal budget, it is, as you both have mentioned, a huge fraction of global total assistance. And Angeli, you mentioned, that the actions now could reverse progress and be wasteful of prior investments. And I think that's a very interesting point of view. And I wonder if you could expand a little bit on how the idea that we've spent so much and it's been an investment that might now be wasted by changing. Could you expand a little bit on that point, which is a perspective I think very interesting for our audience to consider? You're muted.
Yes, thanks so much for that follow-up question, Louise. And I think, I think these misperceptions are really important to talk further about and to really talk about what the truth is. As you noted, we're talking both, Stephen and I, we're talking about a global health budget that is, as you say, less than 1% of the, roughly less than 1% of the entire US budget. When we're talking about the HIV response, for example, and the US contribution to the HIV response, that's less than 0.5%, of the budget. Yet, what we are talking about is extraordinary impact for that investment. The US has been a leader in global health in the HIV response since 2003, when President George W. Bush launched PEPFAR, and just before that, even with the Global Fund and the work that we were doing together on that. Over the past, 24 years, the US has invested over 110 billion US dollars. Now, that is a lot of resource. That is a lot of investment. But what that has delivered is extraordinary. It has delivered over 26 million lives saved through PEPFAR. It's delivered an entire ecosystem of health systems that have delivered not only for the HIV response, but as Steve said earlier, countries were using the laboratory infrastructure, the supply chain infrastructure, the healthcare workforce, the community health workforce for other responses for COVID-19. But we saw it even earlier with H1N1, with Ebola, with SARS. That infrastructure that is critical to stop diseases over there helps make sure that we here in the US are safer and more secure. So, the other piece that I want to highlight here is accountability. These resources that the US has invested in the HIV response, and frankly, in global health, that has resulted in such impact, it's not without a very data-driven, data-informed, and also monitoring of the every dollar spent, where it goes, what it does, a very data-heavy accountability, data-laden accountability system. And that is something I no longer work for the US government, but I am an American, and I am extremely proud of the accountability systems that have been put in place to monitor and track how investment, hard-earned taxpayer dollars are invested in the global health response.
Thank you for that. And Stephen, maybe I'll transition to you to a question which is following on that,
Yeah.
related to accountability and also efficiency. And there is we've been told, and we hear that part of cutting and slashing budgets is to improve efficiency, and that there's waste and bloatedness. I mean, can you give a perspective there on whether there's a lot of or any evidence about that, or is this all about smarter spending, or how are we impacting critical capacity from your point of view?
Thank you. If I may follow, but I'll get to your question just momentarily, but I just wanted to add something to the very important points that Angeli made. We had the president of South Africa visit us last week, Cyril Ramaphosa, and had a visit, in a very dramatic and controversial visit to the Oval Office with President Trump and with his team. South Africa remains the epicenter of the HIV global epidemic. It's been, and it remains that way. And South Africa has been the biggest achiever in terms of making its own commitments, elevating its commitments significantly in terms of owning this response. We've been very generous. It's the biggest account we have within that $110 billion expenditure. I don't know, it's 8 or 9 billion probably at this level. So Cyril Ramaphosa comes to the White House. No mention of PEPFAR in that White House appearance. No note of thanks around that, and no note of alarm at what this may mean, because it's not just the delivery of service, it's prevention, it's adolescent girls, it's key populations, it's the entire remarkable R&D clinical trial networks and lab system that the South Africans have created, which is a sterling set of institutions that have been created in partnership with the United States and others. This issue disappeared from that exchange, and I took that as a pretty powerful proof of the fact that African leadership have been absent from saying a whole lot about the PEPFAR legacy and what it means to remove it. There has been a lot of discussions in the AU and elsewhere around this shows us we have to come to terms with dependence, but something wrong has happened where the leadership were at the forefront when PEPFAR was created, stood up and sustained in its early years in the decade. That leadership's been largely absent in it, and we saw it last week. There were many other pressing matters that needed to happen. On the question of efficiency and the like, the US was 40% of the global health account, total base. Yes, it's a minute portion of our overall budget, which is a colossal budget. DOGE came in and accelerated the assault upon AID and upon other programs. Part of PEPFAR has survived. But what did this tell us? This told us that this sort of revolutionary assault upon foreign aid instruments would be met with fairly limited resistance. The courts have thrown a little bit of sand into the works and remains into the gearbox, and that's still playing through. Congress is coming back now in our budgetary cycle, but it's been fairly weak in this. The guardrails have been largely absent. The argument, yes, has been that these programs are too open-ended. They do not have an end state. There's been delayed calls for reform. And what are we going to see? I think what we're going to see in the future, this all still needs to be defined, but I think what we're going to see is a foreign aid program, global health and other things, that is much smaller staff base, much smaller base of personnel in country. There's going to be much smaller budgets, but there will be budgets, but much smaller budgets. It's going to be very transactional, and it's going to be focused on select priority countries that align with geopolitical priorities. And it's going to be very reform oriented. It's going to be cast as compacts with clear end dates, much more short timeline, and in select partner countries. I think that's likely to be what the U.S. approach will be, and there'll be new financing mechanisms. I think our Development Finance Corporation will play a very strong role, I would predict. It doesn't have its new leadership yet. It's coming up for reauthorization in September, October in Congress. Keep an eye on that, because I think the shift is going to be that way, to new financing, larger grants. It doesn't rule out that this model might still rely on Gavi and the Global Fund and other instruments that we were involved in creating that hopefully will survive. The signals are that we're not walking away from the Global Fund. The signal, we don't yet know what happens with Gavi. That's a very important question. But across all fronts, Pandemic Fund, Gavi, Global Fund, PEPFAR, PMI, President's Malaria Initiative, dramatic cuts, and some programs, maternal and child health is gone. So that reform impetus is playing out in the way that it was explained in the Project 2025 in terms of the critique. But I want to add, Project 2025 had some very positive things to say about PEPFAR. It did not foresee that Musk and Doge would be added into the mix late in the day, at the end of the year, and into the new year, and that would provide an accelerant by which the things went way beyond what even the Project 2025 designers had in mind. And the American public on opinion surveys shows American publics do not like this. American public opinion still strongly in favor of response and commitment. But for now, that doesn't seem to account for a whole lot. Thank you.
Thank you. Angeli, can you speak a little bit now from your perspective at UNAIDS, how the recent funding changes, and especially, I think, the accelerated and the dramatic and very fast changes are impacting programs, frontline services, communities that depend on them? Because I think, as you've both discussed, and maybe we can get to that, like, there have been plans for a transition, and many countries had been taking ownership and budgetary contributions to these programs, but planning that over 5 to 10 years versus it happening between February and May is very different. Could you speak a little bit to what you're seeing and what you're experiencing from the UNAIDS perspective?
Sure. Thanks, Louise. Yeah, at UNAIDS, and again, for the audience, UNAIDS, we are a joint program of 11 different UN agencies, WHO, UNICEF, the World Bank, others. We're at the country level, and we're in countries in all the in all the 55 PEPFAR supported countries. And we're also, since Global Fund is not at the country level, we're also in other countries where Global Fund invests. And so we sort of serve together in this three-legged stool a bit, if you like. When these changes started, these abrupt changes, as you were noting, Louise, when they started, we were there at the country level, seeing it was almost like a tsunami of what was happening in terms of devastation, because the health ecosystem, when there is an immediate stop work that is put in place, that means that everything from healthcare workers, nurses, pharmacists, data clerks, community health workers, warehouses where commodities are, clinics that the US was supporting, everything was coming to an abrupt halt. And that ecosystem was completely jolted. And it's like, you can't just turn on and off a light switch and then everything comes back. So even when the waiver came, which was welcome, when Secretary Rubio issued the waiver for life-saving services to continue, this, of course, was welcome news. But at the same time, USAID the agency, a large implementer of HIV services, was also being dismantled at the same time. So the financial systems, in order to have the funds flow, were disrupted heavily, causing, continued disruption. I think what I would say is, just in real terms, we saw hundreds of thousands of healthcare workers, community health workers, pharmacists, physicians, nurses, data clerks, et cetera, coming to a screeching halt particularly in Africa, where the U.S. invests most, but also in Haiti, where other countries where the U.S. Has invested. We've seen people, clients going to clinics and the doors being closed. We've seen babies being born with HIV when they didn't need to be. I mean, so we're seeing real impacts from the systems perspective to the person perspective and everything in between. I have to say, what we've been seeing lately and what we've been engaging with, and I was there at the World Health Assembly last week, engaging with different ministers of health that have, on the continent, as well as Africa CDC and the Africa Union Commissioner of Health and others. And what we've been seeing from, the end of January to present day is, yes, a devastation and disruption of health services, a slow resumption of health services, but not back to what it was, but also a bit of a silver lining, if you will, which is country governments beginning to step up and really start moving with urgency in a way that we hadn't before. Louise, you mentioned rightly that for the past year and a half, 2 years, we at UNAIDS with PEPFAR, country governments, Global Fund, communities had been working on sustainability plans. And this is not new. It's building on experiences that we've had, in this response from decades prior. Building these sustainability plans. Now, what happened in the last few months is that these sustainability plans went from planning to immediate operationalization. And how do we then do this together? What we started to see is that country after country beginning to find domestic resources from their own countries, putting into the HIV response to try and create. Unfortunately, it's more of a Band-Aid solution. It is, how long can we sustain treatment services during this disruption? It wasn't necessarily the long-term, how do we do this for the long run? So there's a bit of a silver lining that countries are starting to really pick up ownership of their own responses, but we have to continue to work together so that critical services are not neglected or not forgotten, like prevention services.
Yeah, thank you. Stephen, do you want to build on that? You mentioned, and you've both mentioned African Union, and I read an African Union report from last month about financing in a new era. Yet how we're talking a lot about Africa, although obviously there are other continents and countries involved, but most countries are not contributing that much of their GDP to their health services, and this puts a lot of pressure on them. But do you want to build on that, Stephen? Or also you mentioned the World Health Assembly and wanting to comment a little bit on that. You're welcome to bring that into the response as well there.
Thank you. Well, you mentioned the Africa CDC, its Director General, Dr. Jean Kassaya, has taken an initiative in the last 6 months to consult widely among the AU leadership ranks and within the health leadership ranks, and finance circles and prepared a financing plan recently that is phased in its early days, but it was powerful, realistic, smart document. He and his staff, Chanel Hall and others, his entire team came to Washington, D.C. a few weeks ago. We hosted them. They came and presented. I found this very impressive and encouraging that you saw such quick action taken to acknowledge the need to build a financing plan around self-reliance and resilience and sustainability, and put forward new financing options that call for greater domestic commitments, but also blended financing in different forms of options, and some clear targets laid down in each phase on what they want to see in terms of countries coming up with plans, beginning to operationalize them and the like. And I think the language in that document is a language that resonates in current Washington scene. I mean, it was written very smartly to get the attention and sympathy. And you know, when we hosted the presentation, we had a number of Trump affiliated and Trump identified folks in the room, and it was a serious discussion. And so I'm kudos to Dr. Kasaya and his team, and the fact that they're coming. And what we're seeing, it's interesting, we're seeing a cycle of the leadership coming to Washington from the International Committee of the Red Cross, from MSF, from the International Federation Red Cross Red Crescent, from the Africa CDC, coming to not just try and sort out who do they talk to in this very unsettled environment here, but also they're all looking at major adjustments in the financing and in the future, and trying to understand what's in store, but also trying to understand what's the way forward. They're all reducing their staff, reducing their ambitions, but trying to reset. And that's very important, that they be engaged and be coming often and with an open mind and with some concrete reform ideas to put on the table. In Congress, where the bipartisan consensus remains central to whatever is going to be possible in this next phase, but also not to walk away from the administration. On the WHO and the World Health Assembly, obviously the pandemic treaty passed. Angeli should talk about what that means. She was there. It was a big moment. I think that was one of the highlights. There's still a lot of work to be done on the most central equity, the PABS system. That is still not resolved, but they got a treaty. We'll see what happens. Angeli can talk about that. In terms of WHO and its posture, it announced major reforms. I mean, you know, the budget is dropped. The biannual budget is dropping from 6.8 billion to 4.2 billion. The new leadership team, a very impressive new leadership team put in place. They moved from 11 divisions to 4, offices from 76 to 34. This is a very significant thing. They have a very good story to tell, frankly, about the fact that under Dr. Tedros, they rose to this challenge, and not just the US cuts, but others, and have come up with a much leaner and better performing WHO. They have a better story to tell, frankly, and they should. We had Maria Van Kerkhove and Kate O'Brien here week before last, and they both came, presented publicly. We had a podcast. We had a private session with them interacting with Republicans, which went quite well. They need to do more of that. They need to be coming to Washington, telling their story and engaging. I don't think you're going to see a reversal of the US withdrawal from WHO anytime soon. I think probably the next big moment of reconsideration will be when the next Director General is nominated and comes forward and takes office July 1st of 2027, so roughly 2 years out. But right now, the most important thing is to keep a dialogue, try to restore the technical exchange and active dialogue, which was not broken in 2020 when WHO, when Trump first withdrew. They did not break those contacts, which are very important for staying abreast of dangerous unfolding threats around the world. We have a lot at stake in withdrawing from WHO. We're going to pay a price on multiple fronts. We can talk more about that. But I think the most important thing that could be done right now is to restore technical cooperation. It's only been on a case-by-case basis, like the flu meeting that took place. The US came and participated in part of that. Otherwise, they're not joining any of these key committee meetings, working group meetings, and the like, and the exchanges. So we're flying blind in large parts of the world right now, which is in hardly anyone's interest.
Right.
And I think that we should set our sights on that as a next concrete step. That was a theme that Maria and Kate brought forward very forcefully when they were here last week. Thank you.
Thank you. I mean, Dr. Tedros, so, you know, the $4.2 billion World Health Organization budget for 2 years, and countries increased their membership by about 20%. But I was struck by Dr. Tedros' statement that, you know, this was still not very ambitious. And he quoted that the global military spending every 8 hours is $2 billion. And here we are trying to serve, you know, the globe. So I think sometimes too, in terms of budget and financing, we think of billions of dollars as such a large amount of money because it's out of reach for, the notion is hard to even capture for so many ordinary people. And yet when you compare some of these expenditures, it's actually not, it's actually not that much for a multilateral agency. But, and maybe Angeli, to build on that, you're also a board member of the Global Fund, and we've talked about Gavi. Can you mention a little bit how you're seeing Global Fund, Gavi, or other multilaterals responding to these changes? We've touched a little bit on that, but I'd love to hear a little more about that.
Sure, happy to jump in on that. And I think, you know, Stephen was mentioning and starting to talk about this in the WHO, you know, changes that we're seeing happen. So, you know, Global Fund, Gavi, UNAIDS, all of us, you know, all this whole multilateral ecosystem that exists, we're all changing. I mean, there is no going back to what was. We have to change for what the new reality is, and most importantly, what the countries, where the countries are and where they're going. As Steve said earlier, you know, Dr. Kaseya from the Africa CDC and the Health Commissioner, Amma, you know, from the African Union, everyone is really focused on sustaining, you know, it's not just the HIV response, but sustainable financing for health. What does that actually look like? In the HIV response, you know, we are solely focused on how do we support countries to sustain an inclusive, multi-sectoral, national HIV response. And so Global Fund, you know, changes that they're making, it's how to become more agile, how to prioritize further the investment, as Steve said earlier, in global health, not just from the US, but from all other countries and donors, is decreasing. And so we have to collectively figure out then, in a world of decreasing resources, where is the greatest impact possible? Where should we collectively invest, and where should countries, where do countries pick up? For UNAIDS, I could talk a little bit about some specific changes we're making right now, because we too are having our organization. You know, we're going from being present in 90 countries to being present in less than 30 countries. we're focusing our presence on where the need is in terms of the HIV response. And we're reorienting all of our work around this issue of self-reliance. How do we support countries to be self-reliant? I think one thing I'll just note, Steve was picking up on this earlier, you know, the irony in all of this is that for the long, back 20, 25 years ago, HIV and AIDS was high on the political agenda for heads of state, for everyone, right? Because death and despair was on everyone's doorstep. Over the years, and probably because we've had great success in the HIV response, there's been a real complacency or it hasn't risen to the political agenda again. And, Steve raised the point of President Ramaphosa, when he was here last week. But the irony is that it's risen to the political agenda again. HIV has risen to the political agenda again. The fact that, country governments, the Africa CDC, finance ministries, health ministries are all focused around how are we financing this? How are we, I was talking with the Minister of Finance from Zimbabwe last week, where, they had an AIDS levy in, early days in the HIV response, but now they're building upon that, creating other innovative financing schemes and mechanisms to be able to finance the future of the HIV response. And so this is the space where everyone is shifting, getting back to the multilateral shifts. It's really around supporting countries to sustain the responses.
Thanks so much. I've been trying to build in our attendees' questions as we go, but I'm going to shift a little bit in our last 10 minutes and especially focus on those. And Angeli, I'll stay with you to answer this one because I was in Uganda last week and 2 different organizations mentioned this to me, which was about the loss of data collection capacity, which is a very technical component of many of these funding programs. How can we try to sustain or ensure that there is at least data that we can still help to understand? And this came up in a clinic where I was talking with colleagues, and they said we don't even know who's come for their appointment or not. We were spending so much time looking at this data, especially for the HIV programs, but also the demographic and health survey, which was very much supported by the USAID. Can you speak a little to that point about data?
Yeah, sure. It is a real, I mentioned a bit earlier that when the suspension of the US government funding and the termination and all the rest, and the resumption, what was critical and probably fundamental to all of it and to the entire HIV response is the data, right? And we had gotten to a place in the PEPFAR response where there were somewhat parallel systems happening, and in the early days, it was important because the infrastructure, the data, the health information systems didn't have the capacity or the level of detail, that granular level of detail, subpopulation, sub-geography data that was really important to make sure that investments were pinpointed where they were able to have the greatest impact. Data systems, data clerks, data collection, electronic medical records, all of that came to a screeching halt when all of this, the terminations happened. We collectively, UNAIDS with the governments, we are working to revive the DHSs, the demographic health. Those are the country systems. Those are the country data systems that we need to make sure both have the systems have the capacity, but also the users, the countries have the capacity to use the data to guide their investments. So there is an extensive effort underway as we speak to make sure that the DHSs are continuing to be strengthened, because ultimately in the future that's where we're gonna have to go. But it's almost like the HIV programs are happening in a bit of in the dark. Without the data, it's the programs are kind of functioning in the dark, which is why again, this is a critical function that UNAIDS provides, is working with the countries and their local data systems, not parallel data systems. So this is something we're just going to have to double down on and make sure we hold on to and make sure that they are strengthened as we move into this mode of self-reliance.
Thanks. Stephen, I'll direct the next question to you, which is about well, someone has asked a question about moving outside the global health echo chamber. You spoke about bipartisan conversations. We have another question asking from the audience, should we just not even try to talk to those who are in this current administration? But I think what you're both clearly saying is that, you know, there's necessary engagement that's already happening. And also, maybe, Stephen, can you give us some advice or speak a little bit to, you know, the audience of the general public too? Because I think we, in the global health world, have lost the support of many of the general public of the US. Is that because the urgency is not understood or there's misunderstanding? How do you think we can approach that to make sure that we bring people in that are outside maybe our normal networks or our normal, as our audience member said, echo chamber?
Thank you. Those are really the most fundamental questions, and in a way, the most difficult questions. I believe that we were, even before COVID hit, we were facing problems. In the digital age, the emergence of disinformation, misinformation, anti-vaccine sentiment, and the emergence of a populist perspective from left and right, quite isolationist in many regards, quite skeptical of foreign aid. Then we got into COVID, and we've underestimated the power and the longevity of the hangover effects from COVID in terms of plummeting public trust and confidence in science, in public health, in foreign aid, in authority. And so we find ourselves in a situation where these tragic and shocking things happen. Half of the American public basically either shrugs or says that's what he said he was going to do, and that's what we want to see happen. So how do we begin to regain some kind of dialogue around the reality? And I think there's a couple of things that have to happen here. One is the public health world is very sheltered. It's elitist. It's predominantly liberal. It's separate. It's not, the curriculums do not teach people communications and how to reach out and engage with that half of our population that doesn't like them and is deeply skeptical of the work they do. So that's a big problem and a big challenge. I think so it requires a level of humility and self-criticism. It requires a different political engagement and a move towards a greater diversification of political outlook and the like, and a focus on bringing it back to what is the economic sustainability of this? How does this support and bring about a more prosperous and safer American public? That link has been lost. I think when HIV came forward and the American public rose, it was through compassion, because the terror that HIV posed was so visible. It was also for security purposes. I mean, the PEPFAR Global Fund, Gavi Alliance were all in the aftermath of 9/11. They were building new alliances in places that were very, very vulnerable. to these kind of transnational infectious disease threats. But we really need a very concerted strategy of engagement. Otherwise, I think we're really not going to be able to have a bipartisan basis. Everything that has happened in the United States has required presidential leadership and a very strong bipartisan foundation of support in Congress. And both of those are on the table at the moment. But we can't give up on either, frankly. We have to move forward with an eye towards trying to reset going into the future.
Thank you. I mean, and we just have a couple of minutes left. So, I mean, do you think that self-reliance, transactional, economic, health security for Americans, like, do we have to, is that got to be the center of the case now? Or for many people, the notion of justice, global solidarity, interdependence, that was such an important piece of this, and that is such an important piece of this. Is there space for that, or not?
I certainly think there's space, but I wouldn't. I think you're not gonna get any progress in unless you put it in a reset that is focused on reform, smaller budgets, less open-ended, compact-based, much greater country ownership, much more alignment with geopolitical priorities, and certainly in this Trump administration, it's going to be transactional. And you know, President Ramaphosa's argument to Trump was an effort to get the relationship back on track, because the relationship is in such terrible shape, and we can't afford a broken relationship between the U.S. and South Africa. And you notice the pitch he made was transactional. We have certain things we're prepared to do in the economic sphere that will bring critical benefits, and let's use that as a foundation. He didn't say we're no longer interested in social justice. He didn't walk away from all of those matters, and he tried to dampen down this crazy genocidal, you know, allegations of genocide against Afrikaners and the like. But I think that his presence showed the way in which a calculation by the senior most leadership in South Africa has shifted. Mm-hmm. And there was some progress. I mean, he won a tentative commitment from President Trump to come to the G20 summit in November. That's still to be confirmed, but the door cracked open with that appeal. And I think he began to staunch, hopefully, the drift towards a complete breakdown or breach of the relationship.
Mm-hmm. We just have 1 minute left. So with that, I'm going to pass Angeli to you if you'd like to have the last word. Maybe leave us with a little hope for future. Is that, could we? I'm putting it on you.
It's a hard task, but I'll try, Louise. You know, first, I think we're all in the global health space, and the reality is that the end is in sight. We have made so much progress that the end is in sight. And so, you know, I would say, look, there's too much at stake to not finish the fight, to not fulfill the promise. Let's find a way to work together to make sure that we are evolving for the future, but that we are finishing the fight, and we can do this. And so it's a plea, but a hopeful, you know, join us. Let's get this done.
I love that. Thank you. You did that perfectly. Thank you. Let's get it done. Let's evolve, but not give up the fight. We've made too much progress, and we can get there. We can still get there. Thank you both so much. This has been an incredible conversation. I think we'd love to have you both back to talk more and dive into each of these different topics. Thank you so much. To our audience, thanks for joining us. Come back on June 27th. We're going to have a session about the rise of misinformation and that impact on global health work. Thank you all so much. Have a good rest of the day.
Thank you.
Thank you.